All right, if you could all have your seats, we're going to get going. I don't think this magnifies. You're going to have a seat. Dave Powell, Bernice Corley, Dave Powell, have a seat. Bernice, Kevin Moore.
I was like, I can yell if you want.
Hey, it's
once you step outside the floor, there you go.
This is not, can you hear me in the back? All right, we're going to get going. John Hammond is the chair. He is tied up in a meeting. He'll be joining us momentarily. Can you hear me? Dave Powell, come on down. All right, we're gonna get started. We have a lot of presentations. John Hammond is the chair. You may call up people, have them sit down. Mary Kay, have a seat. All right, welcome. We have a lot of information to go through. John Hammond, who's the chair this year, is a little bit. It's on. That's the problem. Can you hear me in the back?
Yeah.
All right. So he'll be joining us, and we have a quorum, so we're going to start with the information. Actually, we can go through the minutes. So you all have a chance to look at the minutes today. Any additions, changes? Is there a motion to approve?
So moved.
All right, second. All those in favor say aye. All right, wonderful. We have a lot of you, personal thanks, a lot of you attended or participated in helping put together the opioid summit. We had over 900 people. We have the comments coming in. I have a lot of correspondence. I see Dr. Havershorn. You've gotten some sleep since then. Just what a wonderful partner in that. So we'll share, if there's time, or we'll post somewhere all the comments that we received. Dr. Chambers as well. I mean, it was just phenomenal. And we were the justice professionals. We can be a tough crowd, and I was overwhelmed with the comments, just the positive, just page after page. Did you have a chance to look at those, Leslie? So a lot of work to be done in Indiana, but thank you for that. Today we have some handouts. We have the Children's Commission annual report, which is sort of important because it marks the 5 years of the Children's Commission. It has a lot of your names and the work that you're doing in it. We'll be talking about approving that. We have the issue briefs from Indiana Youth Institute on smoking, data brief smoking in Indiana, the power play fighting childhood obesity and infant mortality in Indiana, as well as a document which I love, and I'm so thankful the Children's Commission's the Kids Count data book. We're really able to drill down on how our children are doing in Indiana and by local regions as well. So our first speaker today, I want to welcome Bernice Corley. Bernice, she is replacing Larry Landis. You've been around for a while, but thank you. We're sending out a letter to all the judges in the state of Indiana today of Larry handing a running baton off to Bernice. So we're excited to have you here as well. So our first presentation today will be on child well-being disparities. Charlie Gear.
I'm Charlie. It's so good to be here. All of those conversations, they were key. Those themes of
And so I'm hoping that today is a starting place, or at least provides more information for you as you start to think of how do you live into that particular outcome. So here we go. It's in all of our best interest to make sure each and every child is getting support they need to reach their full potential. Each and every child. And so that's the framing for today. The data that I'm going to show you or share with you comes across really 5 domains of child well-being: families and communities, economics, education, health, and safety. And what I want to demonstrate is that disparities exist in all of these areas. And oftentimes in our work, it's easy to become siloed with our areas of expertise. So if you're a health expert, you understand health disparities. But what I want to show you today is that disparities truly exist across the spectrum of child well-being. So who's your kids? We have 1.5 million kids in Indiana. About a third of them live in single-parent families. We're becoming more diverse. Around 27% of children are a race or ethnicity other than white. 10.4% children speak a language other than English at home. We have over 250 languages spoken in our public schools, and around 12% of children are living in immigrant families. But not only are our children diverse, so is our family structures, and as those are becoming more diverse. So we have around 18% of children that live in a household where the primary relationship with the householder is not their biological mother or father. It could be a grandparent, step-parent, adopted parent, and that we've seen an increase in that area. Nationally, so I've given you the latest National Kids Count data book. Your own copy, you have that. So these are the national rankings that just came out in June. If I had to sum it up in one statement, it is this. Nationally, we excel in few, we lag in most, and we need to improve in all. Our overall ranking for child well-being is 28th. This is consistent with last year. Family and communities is 32nd. Economy is 24th. That's a slight decrease from 19th. Education is 14th, and health is 31st. So one of those major themes that I talked about earlier that we've seen across the state is there are clear disproportionate challenges and barriers, and they exist. Oftentimes we think about disparities and disproportionality in terms of race, but it's much bigger than that. We see disparities and disproportionality when it comes to race, place, income, and immigrant status. And so I'm going to demonstrate that for you by going through the different domains. The first one is parental incarceration. Black Hoosier youth are 3 times as likely to experience parental incarceration as their white peers. You see in Indiana, it's 28% compared to U.S. at 15.9, so it's higher than the average, but then you see clear disparities exist for black youth.
I have a question. About 2 years ago, I saw a statistic. We were either first or second in the nation for a number of children who've had incarcerated parents. Are we still there?
I don't know that particular statistic. I'm happy to take a look afterwards, though. When it comes to foster care, we also see disparities here. For those kids that are in foster care, 20% of those kids are black. When we look at the overall number and percentage of kids, just 11% are black. So we see that we have disparities in the children that are in foster care as well. One thing that we've been also focused on is saying, look, it's just not about showing the data, but it's saying, what do we do now? It's the so what and the now what. How can we start to think about this? And so as we've gone across the communities, these are some of the solutions that we've been talking about. And so I've highlighted a few instances where we've done this and where we can think about how we include equity or we think about how we address disparities. So for example, with foster care, how can we ensure that the programming that we're offering in schools considers the foster care parent? How can we bring them in? How do we be intentional with this population and just not leave it to chance as one example of a solution? And poverty. Black Hoosier children are 3 times more likely to live in poverty than their white peers. We see that nationally we're about the same. 1 in 5 kids live in poverty in Indiana, the same as nationally. But we see our black population at 42.2% compared to 34.3% nationally. We're also higher in Hispanic and white as well in comparison to national. We see a big disparity between white and black and white and Hispanic. Working poor households. Hispanic Hoosier children are more than 3 times as likely to live in a working poor household than their white peers. I think oftentimes we talk about children in poverty at 1 in 5, but when you think about working poor, that's 1 in 7. So if you combine the poverty and the working poor, we have 35 to 40% of children that are living in a household that has an economic hardship. And we see there are clear disparities here when you look at working poor, with Hispanic being the highest at 34.6%. Black second highest at 28.3%, and obviously a major disparity there in comparison to white. Food insecurity is another item that has come up over and over and over again in the communities. 1 in 5 Hoosier children are food insecure. And what I'm showing you here is that disparity is very different geographically. So if you look at our lowest county is Hamilton County at 12.6%, then you have your Fayette County, your highest at 23.9%. Not every county is experiencing this the same way. So the question becomes, how are we leaning into this? How are we thinking about interventions? How are we being very specific geographically? As we know, Indiana can be quite diverse from north to south, east to west, rural to urban. Achievement gaps. When we look at achievement gaps really across the spectrum, we see there are disparities. And so this is 2017, grades 3 through 8, passing both parts of language arts and math I-STEP. And so you see there are disparities there with race. You have disparities there with income, for paid meals versus free and reduced. You see it with language as well, from English learners to non-English learners, and in special education. So I think these are things we've been thinking about, but it can go beyond achievement. When we look at students who are identified for special education, you see there's a disparity here as well, where a higher percentage of population of black students are identified. When we take a look at high ability, we see that white students are 3 times more likely to be identified for high ability than their black peers. So it's just not in the achievement, it's in the other programs that we're offering. It can be very systemic. We also see it in school discipline, in-school suspension and in out-of-school suspension. So it's really across the areas that we're seeing that there are disparities. And so it's a matter of us asking why and how do we lean into that? So what, now what? So here are some of the solutions that we've heard that we think are interesting for us to at least consider. How do we empower individuals and parents to ask about equity and inclusion policies within the school? How do we keep the conversation going about these things and think about how we all work together in convergence, not in silos? And how do we continue to segregate the data and making that available when possible? Or just a few examples of how we can take natural next steps to think about this. When it comes to youth suicide, Indiana ranks 3rd worst nationally for this. When you just segregate the data, though, it starts to tell a very interesting story. For those students that identify as gay, lesbian, bisexual, 46.4% have seriously considered attempting suicide in the past year. That is quite higher than their 15.2% for the heterosexual peers. We also see disparities there by race, with Hispanic and multiple races being slightly higher. Infant mortality. We know that the governor has said that by 2024 we're going to be the best in the Midwest. We know we have an infant mortality problem, but when you disaggregate the data, you start to realize we actually have a black infant mortality problem that we really need to address and think about. So how does that impact our interventions? How does that impact our prevention, our messaging, and how we go about tackling this issue, as an example in health? Smoking is another one. When we look at maternal smoking, in Grant County, 31.4% of mothers are smoking. That's significantly higher than our state rate at 13.5% and significantly higher than the national rate at 8%. So once again, geographically, how are we thinking about this? How are we tackling these issues? And just not saying, yes, we have to do something with smoking, but specifically what can we do in Grant, Orange, Jefferson, and Crawford, and Lawrence, and Scott, these counties that are extremely high. Interesting here as well is if you look at smoking by mothers and you look at it and disaggregate it by age as another way to look at this, we see there's quite an increase for ages 18 to 24. Obviously, this is an area where an age bracket where many women are having infants. But we do see there are disparities there, and the question is how can we lead into that? How can we be intentional with that age group? That's another way to think about this. Smoking solutions. How can we deliver culturally appropriate messages that target youth to counter tobacco product advertisements? It's amazing if you start thinking, how are we being marketed with tobacco? And you put that in your mind and you drive around and you start to see all the different places where we are truly being marketed. And so how can we ensure that we're thinking about culture and equity and thinking about location, geographically, race, and all of these things? Obesity. 1 in 3 youth in Indiana are obese. And so what we see here is disparity by poverty level. What's really interesting when it comes to obesity, we know that 1 in 3 children are obese. When you ask parents, 9 in 10 will say their parents are healthy, or their kids are healthy. That's really interesting. So if parents believe their children are healthy, but yet we know 1 in 3 is obese, that's even going into other health issues. What are we doing with parents? What are we thinking about parent education? It raises lots of questions. But obesity is another area. When we just segregate by poverty level, you see quite a lot of disparity. In terms of safety, juvenile justice, youth of color experience disproportionate contact with the juvenile justice system. And so you look at the juvenile and correctional facilities, 32% of those students are black, in comparison to 12.5% of the population ages 10 to 17. Child maltreatment. This is Indiana's lowest ranking. We're ranked 48th for child maltreatment. That includes neglect, sexual abuse, and physical abuse. A new report is given every 2 minutes. So by the time at the end of the meeting today, you'll have roughly 60 to 80 new reports just from today's meeting. So if we look at the disparities here by county, per 1,000 children, Hamilton is the lowest at 2.9, but Vermilion is 57.6. So it's one thing to say that we have an issue with child maltreatment, which is so true. It's another to wonder what is happening specifically in Southwest Indiana, and how can we address that? How can we be intentional about our efforts? School safety is at the top of everyone's mind. When we look at bullying, by gender, we see that female Hoosier students are nearly twice as likely to be cyberbullied than males, as one example to look at gender. School safety here as well, we look at poverty level, or a higher percentage there, as more poverty in terms of feeling safe at school. We see the same thing with race. So to sum it up, it's once again, I'm going to bring us back to the beginning. It's in all of our best interest to ensure each and every child is getting the support they need to reach their full potential. And across the spectrum of child well-being, we're seeing disparities. So how can we lean in that and be intentional and realize that, yes, we need to think about race, but how can we think about place? How can we think about income? How can we think about gender, sexual orientation? Absolutely vital as we dive into this space for Indiana. So a call to action, some very simple steps. How can we communicate this key data and the solutions? I think oftentimes we communicate data, we provide the analysis, but can we go the extra step to provide the solution? Say, here's what an individual can do, here's what a small community can do, here's what an organization, here's what leaders can do. How can we promote access to the data that exists at this table? There's a lot of it. Some of it's public, some of it's not. How can we ensure that we get even more data out there to drive change? The word collaboration, I think, is a great word. I like the word convergence, which means how can we work together towards a common goal? I think collaboration oftentimes can be self-serving. What are you doing that I can take and apply in my own context? So I encourage us to think as a state, how can we work in convergence to make a difference? And obviously there's a lot of influence at this table, so how can we maximize that? IY here is here to support you. We do data requests constantly for individuals in your agencies and across the state. I really appreciate the opportunity, Julie, and everybody just to come and speak and say, hey, here's what we're seeing. This is what we're seeing across the state as we've gone and traveled over 50 sites this year. So, any questions?
Yeah, we have a couple of minutes if there's some questions. Julie, are we looking at some of the data points and the solutions and seeing if where they fit into the Children's Commission's strategic plan and some of the specific outcome objectives that we're looking at?
Yeah, so if you all remember, when the strategic plan was approved, there was also an operational plan that was more about kind of how is the commission going to function, and there was a stated objective in there to ensure cultural competence. And so as I've been kind of thinking about that and how to make that real, that was sort of the reason for having this presentation. And then the next step will be exactly that. It'll be for us to figure out now as a commission, how do we want to apply this kind of lens to everything that we do. So yes, we'll be looking at the data within each strategic priority area, and we'll talk about that more, I think, at the next meeting.
Any other questions?
Yeah, a lot of our data sources come from state and federal agencies. We have also some really specific data that comes to, say, like the Youth Risk Behavior Survey or the National Youth Survey, things like that. So we use all national surveys or we use state and federal agencies to gather the data. And oftentimes...
But you've got it like in light under each data point you've got where, okay.
Oftentimes we try to include, if I've forgotten one, I'm certainly happy to get one for you.
Do you,
None of it is primary research. It's all secondary that we've pulled and disaggregated and looked at.
you know, like the smoking data and the counties on that? That'd be really interesting to see with regard to our partners. We all have people that are working in those agencies. That's one of the leading causes of infant mortality, correct, Dr. Worthall? Smoking when you're pregnant? Okay. So yeah, I think, thank you, because this really helps us frame where we appreciate this.
I think another resource, the Alliance for Healthier Indiana, if you're not aware, they've a group of hospitals and the hospital association have come together and are doing a roadshow across the state, and we've been grateful to be a part of that roadshow as one of the speakers and bringing to forefront really how is obesity, how is smoking, how is addiction, and how is infant mortality impacting families and kids. And there's a lot of energy statewide specifically around smoking, I could say.
Thank you very much for the presentation, very enlightening. Just want to follow up with the question in regards to smoking. Do you have any data in regards to programs to quit smoking and their effectiveness?
I know that data does exist in that space as really work to think about how do we, the impact of tobacco and what that works is well documented, right? It's something that we've been thinking about as a state or nationally, different groups for a long time. So there are programs that are well documented.
I'd like to see how effective they're being, or the conclusion when you finish the program, how many stay away from smoking. Interesting that my guess is it's pretty difficult. And my other guess is I don't know how many actually, even going through a quit smoking, maybe one time or multiple times, success rate is fairly low. That's just from data that I've read, and I don't know if there's a different direction we need to take to try to increase the numbers of those who completely stop smoking after going through the program. Thank you.
Other questions? Thank you. And thank your whole organization.
Charlie, wanted to quickly just let you know, and of course, everyone around the table, welcome, Dr. Box. So both ISDH and FSSA have launched health equity offices. Again, not as separate groups, but as the overarching lens to how we deploy all of our work. For Dr. Box's agency, and she can speak more to this, it's for accreditation purposes. That's now what health departments are supposed to do. Not just based on individual infant mortality or smoking or obesity, but all of it. The fact that we can do that in collaboration also within social services and healthcare delivery, I think will make us much more effective, much more quickly. And so we have, for FSSA, we have a two-part system. Our health equity office is run by our new chief medical officer, who started now, I think, 10 days ago. We're very excited about having him here. But then our social determinants office, which we call the Healthy Opportunities Office, started in January. And the work that they're doing to take not just the information on what we do with SNAP and TANF and Medicaid and Healthy Indiana Plan and Voc Rehab and all the rest, but layering that with information about the things that we need to know about disparities and social context, so that when we talk about where we need what, we're not putting blanket programs in place where they're not necessary, but we know exactly where we need to go, we know exactly with whom we need to partner, and we have the flexibility and nimble movement so that we can, if we have a transportation issue here, we partner with transportation groups in this area, and if we have a housing issue here, we partner with those groups. And so this information, and we share much of our info with you. I think this, I think a lot of this comes from us, and so the fact that we're all thinking with the same language, with the same lens, is the only way we're ever going to make our way out of. We are a little bit competitive, and so we don't like being at the bottom, and so I think we're really working together with, I think, partners that we've never thought about before. It's not public versus private versus philanthropy, it's all of us together, and so we are, I hope that you'll find a much more collaborative environment that perhaps you've found in the past. And then also to throw Dr. Box as well, she has all the data on smoking cessation programs and how they work and which ones are effective, and we'll get that to you.
If I'm a judge or probation officer in a county that's the worst in the state, I'm probably going to add that as a term of probation. But I want to make sure we're using evidence-based programs. So I think a list, here's the problem, because we're sort of a hook. Sort of the coercive intervention of the court can often be a beautiful thing on moving the needle. Not everybody thinks that. The recipients necessarily. But I'd love to, while you're doing that, we need that knowledge so that we're not using programs that aren't effective. We put together, we worked with FSSA and Dr. Haversham and Dr. Worthall, and then we kind of ran up the chain to do sort of a medication-assisted treatment, what is best practice treatment for substance use disorder, and we sort of ran it up the chain. We put it in a bench card for justice professionals. It would be nice to get these bench cards out for people that are ordering and getting people to treatment. We know SAMHSA says the number one referral source for drug treatment is the criminal justice system. We're hungry for information on what works to get that needle moved, so send it our way. Okay, great.
Thank you very much. And Dr. Walthall, please know IY is here to help and partner with your work. Okay, thank you.
All right, next we've got strategic priority of child safety and services. We have Victoria, Julie, Chastity from the Child Services Oversight Committee, working Representative McNamara, and you're going to give a report with regard to the Child Services Oversight Committee. Anxious to hear it.
Thank you for allowing me to speak this morning. Here for Rep. McNamara, giving the update on the Child Services Oversight Committee. The committee last met on July 18th, where we heard a presentation from Director Stigdon about the progress that DCS has made in regards to implementing the recommendations of the DCS assessment conducted by CWG. The director also gave an update as to the agency's progress. She stated that the agency has been working on decentralizing decision-making, recruiting more foster families, hiring data analysts, making salary adjustments for staff, and developing legislative proposals for 2019. And so we kind of reaffirmed the Oversight Committee as the best avenue for DCS to report on its progress. And our next meeting is September 18th, where we will hear again from the agency about its progress. And then in terms of legislative recommendations, Representative McNamara is deferring to the Interim Study Committee on Courts and the Judiciary as a legislative council assigned that committee to study the assessment and the recommendations. Are there any questions?
Any questions? All right, we look forward to continuing to receive the report. I just wondered, Julie, do we post, and I know Director Stigdon, you provided a lot of information with regard to all the many things you're doing. Do we post those reports on our website for the public to see?
The agendas in the minutes, yes.
Any documents that are handed out?
We haven't done documents for the committee meetings. We could. I mean, we can post anything.
The rest of us, so you're not repeating the...
I don't know that there were any documents at that meeting. I think it was primarily a verbal update. Yeah.
Thank you. All right, Dr. Havershorn and Sarah Sailors, a report on the Zero Suicide Academy and Task Force update.
Having us. Okay, so quick updates. So the Zero Suicide Academy took place on the 25th and 26th of July. There were 11 participants, and the names of those will be provided in the minutes because Julie has those. Hospitals, mental health centers. They are going to continue to engage with the host as well as with the State Suicide Prevention Coordinator, Jason Murray, on a monthly basis to continue to implement that model within their systems. There's plans and hope to have more of these academies as well to catch even more folks. And then related to suicide, so because that falls within our subcommittee or task force, I guess we're called. We have a number of different entities coming together with the same concern, and that concern is that in the age of online reviews, parents are when they're faced with their own child needing emergency services for the treatment of suicide, what we're seeing increasingly around the state are parents refusing treatment because they will Google the facility and look up the number of stars it got and refuse. And so it's an increasingly common problem, and it's challenging to figure out exactly how to handle that through child welfare or commitment statutes, things like that. So our group's going to take a look at that. We're just starting that. And then the new thing that we've finally convened is the safety and well-being of children in state care. So we now have Chris Daly from IARCA, which is the Indiana Association of Resources and Child Advocacy, leading that. and representatives from DOC, juvenile detention facilities, speeds, state hospitals, et cetera, to work on that topic. So we're just getting going with that. And then we'll be back in December to give some updates and requests from the group around the trauma-informed initiatives. And then you'll hear now from Sandy Runkle on our child abuse prevention work and Brent Kent from the Older Youth Subcommittee. Any questions for us?
These academies, when you say you're going to move them around the state, and it's the health. Who are the attendees of those?
So the attendees are hospitals or community mental health centers. And so we have the list, so there were 11 of them. We could have accommodated more. One thing that I learned in the process is you have to be ready to go as an entity to sign up for one of those. And so for many partners around the state, for example, Riley Hospital, that started a conversation that will lead to sort of 6 months of preparatory work in advance of the next one. So it takes a while to get ready. You have to do a needs assessment of your system, and it's not something that you can do really quickly. So I think there will probably be more hospitals that will sign up for the next round after having heard about this one. So I think the goal is definitely to keep doing it, and they occur around the state. Like there was one in Ohio a couple weeks ago. So, and we could go to those if we wanted to, people from this state. So I think the word is out that this is a great model to deploy, and I think we'll see more utilization of that.
Questions? All right, so we'll hear back from your task force in December with regard to you're going to be asking us for action items.
Well, one research presentation and then an action request today from 2 of our groups, and then we'll be back in December for some more other ones.
Great. Sorry I'm late. Thank you for being on the floor. Next up is Sandy Runkle, Child Abuse Prevention Subcommittee.
Usually loud enough.
I wish I had brought my glasses, so forgive me if I have to look down occasionally. I'm Sandy Runkle with Prevent Child Abuse Indiana in the Villages of Indiana, and I'm also a part of the subcommittee for child abuse prevention, which is a subcommittee of the Child Safety and Services Task Force. And we've been meeting for several months, and we were initially tasked with 2 areas. The first area being try to list as many child abuse prevention resources that we could think of in the state of Indiana. And so what we decided to do as a subcommittee is really stick with primary and secondary prevention resources. So for instance, you're not going to be seeing the Department of Child Services on the list that you were provided. So we also decided, keeping that in mind, that we really wanted to kind of expand that list to include, resources that may not have traditionally been thought of as child abuse prevention. So food, nutrition programs, educational programs, and that kind of thing. We really want to expand that notion of really what is child abuse prevention. So we came up with an initial list, and then we sort of dug a rabbit hole of our own. As we were going through the list, we started talking about the fact that, at least anecdotally, we were hearing that a lot of providers were not aware of each other, not aware of the resources that were being provided. So that kind of alarmed us, and this is something that we've been kind of hearing over the years, again, just anecdotally. So we thought, what can we do, to sort of measure that, and then what can we do if we find that to be true, where there may be siloing or there may be a lack of awareness around, what resources are out there in the community. So we did a very unscientific, informal survey, and we sent out the initial list of prevention resources to over 800 individuals. And we just asked them simply, have you heard of this resource or not? And the answer was either yes or it was no. And we actually received pretty good feedback. We got about 225 responses back. And it was, a little bit concerning. We had the opportunity to look at some that we thought, wow, we hope this has been heard of before, like Connect to Help, and we found some good responses there. But then others we had some concerns about, and the results are in your packet. But what we were concerned about were those entities and those resources that we considered to be statewide or had a really far-reaching impact in Indiana. And those are the results you see here, because we realized, there's some resources that really were community-based and locally based. So our concerns were really the resources that were considered statewide, or again, had what we perceived to be a far-reaching impact in the state. So again, those list of agencies are provided. And I won't go through all of the results, but you can see that, we listed, along with descriptions, some of the programs that we had results that we were a little bit concerned about. And by the way, please stop me if you have any questions or anything about what you're seeing or reading. So you can see, that it goes from like 61% down to 10%, and everything in between. So again, it was unscientific and very informal, but it gave us sort of an idea of, is there that concern about resources not being aware of each other? Because that, you want everyone to know, okay, if I have a client in need, here's where we can refer them. And if that knowledge is not out there, then what are we missing for this, the families whom we serve? Then we're concerned, okay, would this indicate maybe a gap in services? Or on the other end of the spectrum, maybe there's duplication of services. So this was in part some of the pieces that we were considering as we were going through this list. Now, the other really nice thing about the survey is at the bottom, we asked, if you know of some prevention efforts that you did not see listed here, please add to that list. And we really got a nice response, and we have several more prevention programs that we got to add to that initial list, and that is also included in your handout. And we like to think of this list as fluid. We still probably have not thought of everything, and then probably even the last several months, maybe new programs have developed. So that list is obviously somewhat fluid. So in terms of next steps, with regard to this piece, we, as a group, decided that Connect to Help 211 was the most natural entity to handle, the resources that we came up with, and what we plan to do. In fact, I think Julie has already talked to Julie Johns-Cole, who is the head of 211 Connect to Help. And what we are planning on doing is giving this list to Connect to Help and ensuring that they have all of the services that are on this list, just to ensure that they have the most complete list as possible. And it might not be a bad idea for Julie Johns-Cole to at some point, even come here and talk about all the services that they provide. But we decided that was, again, the most natural fit was for 211 to sort of handle all of these resources. So we need to ensure not just that 211 has these resources, but what we would also like to do is connect with those entities that for us maybe didn't appear to score as high on the surveys, and let them know, here's what we found out. It was very informal, but just so that you know, here's what the survey results indicated, and then let them make, the most informed decision about marketing or, ways in which they can kind of get their message out about their particular resource. So those were our next steps with regard to the prevention activities. And I guess we would ask this commission if you could provide any additional ideas about how to best increase the knowledge of service providers about existing resources. I know many of you head up state agencies, so if there's anything that you would be able to do to aid us in this endeavor, because we don't want gaps, and we certainly want whatever is out there to be known by the communities.
Sometimes I think people need to see each other and connect a face with the organization. So I guess I would suggest some sort of provider fair or swap information months, or come up with something that get everybody in the same place, or representatives from everybody in the same place, so that they can get familiar with each other. People are not going to use people that they don't know. So, and I just think sometimes we need to bring it back down to the human factor and put everybody in a room together so everybody, I think that's what we have these great resources around the state, but people don't know about each other. So, we got to introduce, people to each other. Putting it in 211 is okay, but I think also putting it, and I'm not on my.
Yeah, push the make it green too. Thank you.
I'm sorry, I wasn't on the microphone. I just think that we need another step.
There's a lot of concern with rural communities, and we hear a lot, we don't know what's there. What if we would take your information with what's available statewide in these communities? And I just asked Director Stigdon, she goes, her employees get training on it. We don't, but if we could map out where those resources were, the U.S. Department of Agriculture has a lot of resources too with regard to that, some wonderful mapping and resources that are available in rural communities. That would be a start. So I don't know, between Julie and Tamara and the data sharing and mapping committee, if we could map out what's in the communities, it'd be nice to be able to say, here are services. So, and then they'll know that each other's there, and we can send them a copy of the mapping and a meet and greet.
I still think a meet and greet. I just think that we need to do everything for our kids, and we got all of these resources, and people don't know each other. And it's just a simple fact that, it doesn't necessarily, do it regionally. If that, everybody can't come to Indianapolis, but then do it regionally. Have some sort of meet and greet where people know each other. Then you know the services. That's I don't know, I come from, I'm a community worker. That's what I do. So I just think that it's easier and nicer when people know each other and can help each other. And if we're just trying to help our children, I think that we need to take another step. 211 is nice, but if Sally don't know Joe, Sally can't help Joe.
Maybe this is a question for Julie or Sandy. On the action requested, is it merely that some of these services that were surveyed or the prevention services get passed along to 211 to potentially incorporate into their?
Yes, thank you. Yes, and we'll be doing that as well as with the other entities. It was sort of for informational purposes for you, but also, obviously, you just came up with 2 great ideas, so it was also asking for your input as well. Thank you.
There's a second action request, too, so maybe we can move on to that one.
Dr. Box?
So, the second task for us was just a small task of preventing child maltreatment. So this one took a little bit more. Maybe that's why we dug the other rabbit hole. We were trying to figure out, okay, how are we going to master this? But I think we at least can do this in steps. So again, keeping in mind, expanding the idea of what is child abuse prevention. Who does that involve? And that involves all of us, not just the government, but it involves everybody in this room and actually everybody in the community. So keeping that in mind with that expanded view, we came up with a lot of wonderful ideas. What can we do to improve, workforce development and income levels, disparities, education. All of these pieces may aid in supporting families. So all of this was out here, and we thought, how can we get it in here? How can we contain all these ideas and make this possible? And for years, Prevent Child Abuse America, for instance, in their policies or best practices, they have indicated you really need a statewide prevention framework around child abuse prevention. And some states have gotten on board with that. South Carolina, Nebraska, Colorado have done statewide prevention frameworks. And it is even becoming, some best practice we see in the government. I think I put in my report that the last RFP from the CDC actually required some kind of statewide prevention plan before somebody could even apply for funding. So this is starting to become something recognized as best practice. So if we were to provide a statewide framework around child abuse prevention, it encourages collaboration, it honors local communities, it encourages data sharing, which is what you were saying, Chief Justice Rush, and it encourages best practice models. So in our work and in our thoughts about a statewide framework, we learned that many agencies around the state already have statewide plans that focus on their own populations. And we thought, wouldn't it be great if we could have access to those statewide plans that already exist, examine them, and see if there's a plan that's already out there that we could incorporate child abuse prevention into, or one that has a good foundation upon which we could build. So we are asking the Commission to please endorse that agencies or entities that have a statewide plan, be it strategic action framework, if they could provide that to our overall task force, so that we can examine those plans and again see if there's one already in existence before we come back and recommending kind of comprehensive statewide framework of our own.
Dr. Box, I think you had a question.
Well, I was just going to say, back on your other remark, mapping
Thank you.
We're working pretty diligently within our social context office to have that as something that we don't have to do a survey to keep up to date all the time, but actually have it as a living, breathing
place that has a natural direct referral connector. So we love the partnerships with 211. In fact, our Open Beds program is embedded within 211 so that it's a 24/7, 365 operation. It needs to go just that one step further so that it has access with at a touch point for an individual practitioner who's sitting next door to the mom that she's charged to take care of. So we're really excited to partner with you. This is independent of disease process. I call it disease agnostic, which is maybe the wrong phrase, but really building a health infrastructure that is focused on prevention and wellness rather than reacting to things when they're way too far down the line.
Thank you.
So Julie, if you'll repeat to us what the action requested is exactly, and then we can see if there's a motion.
So the request is that any of your agencies or any entity, I think even maybe non-governmental, that has a statewide plan, kind of any kind that would impact children or that would broadly have an impact on child abuse prevention, that plan be submitted to the Child Safety and Services Task Force. And you can do that through me and I can get it to them so that this subcommittee can kind of assess, do we also need a child abuse prevention statewide framework, or do we already have something there that exists or that could be built upon?
So do we have a motion for the task force to continue in that discovery?
So moved.
All in favor?
Aye.
All opposed? Motion is approved.
Thank you
Recommendation is approved. Thank you, Sandy. Next up, we have Brent Kent and Joshua Christian, the Older Youth Subcommittee.
Good morning, everyone. Thank you for allowing us to present today. And I apologize to our viewing audience, but I left out a couple important slides. So I'm going to have Joshua pass those out, along with a brief summary of the Family First Prevention Services Act. It's a little relevant to what we'll be discussing today, and I think has some other things in there you might be interested to read about. My name is Brent Kent, and I'm the president and CEO of Indiana Connected by 25, and I'm joined today co-presenting with Joshua Christian, who is a member of the Indiana Youth Advisory Board. And the point of our conversation today is just to discuss the unique needs and unique challenges of older foster youth, which themselves comprise a distinct at-risk subgroup within our foster youth population. Is this going to? Okay. Okay, perfect. So today we're going to talk about what those unique challenges are for older foster youth, and then a little bit about the research around the benefits of extending aftercare services or extending, in some cases, foster care services for that population. And this comes out of the CWG audit, or the assessment of Department of Child Services. One of the recommendations of that assessment was to extend aftercare services to age 23. So a little bit about Indiana Connected by 25. We are a statewide nonprofit organization that works with older foster youth. We partner with the Indiana Department of Child Services. We provide a lot of the state's programs and services for this population on the department's behalf. But our goal is to help older foster youth make that transition into adulthood successfully and on their own. So our mission population are those young people across Indiana between the ages of 14 and 26 who spent at least a day in foster care after age 14. And that seems very specific, but the reason is if you're in foster care at age 14, your chances of finding a permanent family greatly diminish. And even if you do, unfortunately, life outcomes for that population are particularly dire. So we start working with them, providing them the skills and the resources that they need to make that successful transition. But that population in the size of Indiana, 14 to 26, who experience foster care as teenagers, is just under 22,000. So for comparison, that's the size of the city of LaPorte.
Hi, I'm Josh Christian. I'm an incoming junior at Marian University, and this picture up there, that's Dr. Milner there. He's the acting commissioner for the Administrating Children's Bureau and Youth and Family Services, and the associate commissioner for Children's Bureau. So I'm a Jim Casey Young Fellow, and a Jim Casey Young Fellow is an initiative that has 17 sites, and one person from every state is accepted into it every year. This year that happened to be me. I'm also an Indiana Youth Advisory Board member, where we do advocacy work on the state level. And then There is not a bullet point up there, but this year I received a National Foster Club Award for my advocacy efforts in the state of Indiana. So.
I can't overstate what a big deal it is being named a Jim Casey Young Fellow. And that means not only the rest of this year will Joshua travel the country and learn and do deep dives into public policies around child welfare, but for the rest of his career, he will be part of this alumni fellowship that works with the White House on child welfare recommendations, that today our previous young fellows from Indiana are authoring books on child welfare. So hats off to you, Joshua. So a little bit of a background on extension of foster care. Until 2008, in most states, foster youth aged out at age 18. And often what that looked like, because foster youth are delayed in their educational journey, they hadn't finished high school, and they're leaving their foster care placement, and for many of them, the next step was a homeless shelter. But in 2008, federal legislation allowed states to extend foster care up to age 21. It also allowed states to extend aftercare services, which is a little different, and we'll get into a little of those weeds later, to age 21. Indiana was one of many states who extended foster care. We did so to age 20, and then we extended the aftercare services to age 21. And I believe the wisdom at the time was that that would allow for foster youth to have a 1-year off-ramp of supportive services to make that transition out of foster care and into adulthood. Let's see. Well, I'm really bad at advancing slides. So here is a little bit dated map of the other states that have extended foster care. For a long time, Indiana was the only state that opted to extend, but only extended it until their 20th birthday. But today, many states have extended it to 19 and a half or 20 or 20 and a half. And this goes to those couple of slides that I left out. So earlier this year, the Family First Prevention Services Act was signed into law. And this allowed states to extend those aftercare services to age 23. But it only allows states to do so who extended earlier foster care to age 21. And then the next slide I have just pasted the recommendation from CWG. So we're not going to really get into that recommendation. We're going to start talking about what that population looks like in Indiana. So here's a snapshot of older foster youth in Indiana. So we have about 5,200 youth in Indiana over the age of 14 in foster care. And you can see the breakdown of that group. And as Charlie mentioned earlier, African American youth are overrepresented in our foster care system. This reflects national averages or national trends. So about 18% of our foster care population are those 14 or over. And this is 2015 data reported by the state to the federal government. And this represents the reasons for leaving care. Something that the CWG assessment noted is that Indiana has a higher than national average percentage for youth leaving to permanency. That's something you want to see. That means they've been reunited with their families or they have found new families. And so that we're about 10% higher than the national average, and something we should commend ourselves on. But this red, that's what's concerning. So these are the youth who age out of foster care, and for whom life outcomes are particularly negative. So now we're going to talk about the Midwest Study on Foster Youth. The longer name for this is the Midwest Evaluation of Adult Functioning Former Foster Youth. This Midwest study unfortunately did not include Indiana. It was foster youth in Wisconsin, Illinois, and Iowa. And what's unique about this study is that it's longitudinal, so they were able to track their outcomes at 19 and again at 21, but it compares life outcomes for foster youth to that of the general population, i.e. youth not in foster care, youth with supportive families. But it also compares foster youth in states where they age out at 18 versus states that have extended foster care or extended services. So what do we know about our population who are aging out of care? They suffer from rates of post-traumatic stress disorder at over 2 times that of combat veterans. Fewer than half graduate high school by age 18. Again, I want to remind you, these are not Indiana-specific statistics. In Indiana, we don't track high school graduation rate for foster youth. Yes, we are getting ready to.
We're tracking now.
20% will be homeless within 2 years of leaving the state's custody. 71% of our females in foster care are pregnant by age 21. Most of those, it's multiple pregnancies, and many of those children, unfortunately, themselves end up in the foster care system. So foster care is, and particularly as it relates to older foster youth, a multi-generational problem. So compared to the general population, about half of us, and this is the tropes about millennials, 50% are living with their parents until they're 24. And then parents provide an estimated $38,000 per child between the ages of 18 and 34 in material assistance. But what we see for youth in extended foster care or receiving aftercare services, that they are 2 times more likely to pursue post-secondary education. They are, I think, 2.5 times more likely to finish college. We see a great reduction in early pregnancy. We see a reduction in homelessness and involvement in the criminal justice system. And there has even been research on the cost benefit to our community. So Jim Casey, a group under Annie E. Casey, calculates that for every foster youth who ages out of care, the average lifetime expense to the community is about $300,000 due to early pregnancies, involvement in the criminal justice system, and other community services.
So I believe that it's important to extend services to 23 because the state is responsible for all foster youth aging out of care. Our brains are still developing, and this is a critical part in our lives. And youth who are aging out of care will attend 4 different high schools. I'm a prime example because I attended 4 different high schools. But 49% of foster youth have completed high school by the age of 19, and 1 in every 4 youth will become incarcerated within 2 years of leaving care. Also, within 2 years of leaving care, 1 in 5 will be homeless. Personally, I've been at 18 homes, and I am behind in my education compared to my peers. 41% of youth have 3 or more placements while being in foster care. And then when it comes to Indiana services, collaborative care is important. When the youth turns 18, they can enroll in collaborative care, which will aid them in the transition into adulthood until age 20. At age 20, youth can enter voluntary independent living services for 1 year, which helps them transition out of foster care. Currently, that support ends on your 21st birthday. I had mine last week. And then I loved my independent living worker. He was awesome. He was a foster youth himself. He went the whole 9 yards. He helped me complete my FAFSA. He helped me get into college. He led me towards financial security. He was great. And leading up to the presentation, we surveyed other Indiana Youth Advisory Board members to see what they had to say. And almost everyone commented that they would use these services until age 23. Here are a few comments. If it was extended, it would help a lot of teens in college who don't have the positive attitude to stay in college. I feel some students have gone through overwhelming events in their lives and have less drive to stay on track. Financial funding with housing and other areas, finding jobs, planning for life after college, help learn things you need to be successful, and more foster youth will succeed if there is an extension because there is just more time to have support while adjusting to adulthood. And so nobody's in the same situation, but as the Indiana Youth Advisory Board member and the Jim Casey Young Fellow, I believe these services are important and they will help young people. So from here, we're going to open up the floor to questions.
Thank you, Joshua. And I will use my own personal privilege here and might want to invite you back after you finish your tour to hear what you found in other states as well. So thank you for being here.
Is there an action item with regard to supporting this recommendation?
Not at this time. I know that DCS is working on their legislative agenda, so we're gonna wait on that.
Thank you, Brent. Thank you, Joshua.
I was just at John. I just want to comment along with the same bad statistics. I was at a human trafficking conference, and the average age that starts is 15, and 77% of those females were former foster DCS children. So this is the pipeline for human trafficking as well in our country. So there's a lot of bad data around these kids that are in these systems.
I also wanted to say I was recently in Denver for the NCSL Child Welfare Fellow, and they had 2 foster care children that presented that were adults that talked about not only being, I think one was reunited with their family, and then one kind of aged out the system. And they talked about along the way the things that that as children, they knew what was going on, but weren't necessarily talked to about their particular situation. So I think and about having support and financial support from the state, especially when you don't have anybody else. So those were some of the important things I did take away from my time away, is, you know, being able to talk to those 2 young adults. They're young adults now. And I don't know, they're some sort of fellow, but I don't know if they're the same. Yes, it was an African-American female, and they stay on for a year, and I think they're getting ready to come off.
We recommended you to be included in that, actually, because you worked with us on a bill for foster youth last year, so thank you.
Okay.
Knowing this population, I mean, I would support recommending it now and not having it come back again. I mean, while you put together your budget, or while you look at the different things, well, the Children's Commission looked at this, and we support extending it. There's a lot of hoops that you've got to go through, and there's a lot of funding that we've got to find, but I don't see, so I would like to make a motion that we recommend that these services be available to foster youth up to the age of 23.
Do we have a second?
A second.
All in favor?
Aye.
All opposed? Hearing none, recommendation is approved. I will say also, just as an aside, we're way off track, sorry, Julie. But that was a really important discussion, and thank you for making the motion. But there was also a study committee chaired by, I believe, Representative Stewart-Wald. Moving forward, I think the first one is on September 5th, and I think the second one is maybe September 19th,
It is.
where they'll address this issue as well, and talk about this along with a number of other the CWG recommendations that might be addressed legislatively. So thanks, Brent, thanks, Joshua, and we'll get back on track. I know Don Travis and Judge Pratt are here, I think, or Don?
Thank you. On behalf of Judge Pratt, I apologize. He has a docket today, which makes him unavailable for today's meeting. I just have a quick update. As you're aware, our task force has been kind of laying a foundation this past year towards moving forward on a number of initiatives from our charter. And those include support the enhancement of services across the juvenile spectrum, evaluate status offenders, supporting funding for innovative youth programming and expansion of possible increased funding, support the ongoing efforts of the commercially sexually exploited children. So we've been working on those issues for about a year now and laying some foundation. We've had some conversations with Pew and CSG. We've actually, 4 of our task force members actually attended a conference during this last meeting in June sponsored by Pew to kind of look and evaluate Pew and what they've done for other states. It was very interesting, and we received information from several states who've been working with Pew for several years. Some of the project emphasized models providing evidence-based practices throughout the states. Georgia has 162 or 168 counties, and they've been able to put evidence-based programs in each one of those counties to affect juvenile justice. There's also another state that talked about incentivizing diversion programs for juveniles, and that meets both 2.2 and 2.6 of our charges. So it's very interesting for us to learn about how these states were doing that. When it comes to the status offender, we learned several presentations were made, particularly on, not to hold Georgia up there, but they have MOUs with their school corporations and how they were dealing with the truancy, in particular down there, that takes it and removes it from the juvenile justice system. There's actually one state talked about how they removed truancy from the delinquency code and placed it under the Department of Education with the at-risk funding, and that was something that was very interesting. I'm not suggesting that right now, Dr. McCormick, but it was interesting to hear that what the states were doing regarding truancy around the country, which then again falls into 2.5 of our charges. Other themes of the presentation included removal of delinquent children from, delinquent children from home and place either residential or incarcerated youth. And we really drew a conclusion there as we need to look at the recidivism rates for those individuals that are placed either residentially or placed in the Department of Corrections to see if we're really truly getting a bang for our buck. At the end of the day, what we concluded from that is we like to continue to pursue our relationship with Pew, and we are in contact and working with them. But we did notice a couple different things. Our committee or our task force is deficit, mainly of legislators, and in order for Pew to come, they would like all three branches. So at our task force meeting last week, we delegated a subcommittee to start working with Pew, and we would like to reach out to the executive committee and talk with them about how we bring on some legislators, some key personnel to our task force, of the subcommittee of the task force, to look at this process. From there, we're going to look at developing sound bites and how this looks, and developing some key stakeholders as we prepare for this. And we anticipate we could be working with Pew sometime in the beginning of next year, maybe May, March, somewhere in that time frame, but we're continuing to contact with them. In addition to that, our CSEC task force has been pursuing the charge of the legislature for them to look at that holding time. They have had 2 meetings now, and they're in the process of evaluating the information they received at those meetings. They should be coming to our task force with some recommendations, and we'll bring that up at the next meeting. It was interesting, as a side note, that one of the things that the CSEC group came up with as a possible recommendation is to look at shelter care across the state, and it's interesting that that's also under our charge. It's 2.1, so a lot of these things are tying together for us. That's all I have.
Any questions? Thank you, Don.
Thank you.
Next up, we've got the Mental Health and Substance Abuse Task Force. Center Head, Cyril Blackman. Welcome.
Welcome, and good morning. Thanks for having me this morning. I'm here on behalf of my co-chairman, Cyril Blackman, to talk about some recent accomplishments and what we're trying to do going forward. I know, she's back there. And she'll tell me everything I say that's mistaken. But I'll probably need that. In the most recent legislative session, our task force worked on 3 bills that passed. Probably the most important one to the commission is Senate Enrolled Act 224, which you endorsed. As you recall, our standards for licensing for clinical social workers, mental health counselors, marriage and family therapists, and addiction counselors required 1,000 hours of training, of face-to-face supervision and an internship. National standards in all the surrounding states required only 700 hours. So the upshot of that was that we were chasing good people out of these professions where we have shortages, encouraging them not to come here and encouraging those who got their education here to leave. And with your help, we changed all that, and that passed unanimously in both chambers and was signed by the governors. And thank you for your approval and your help on that. And the task force also helped with Senate Enrolled Act 223, which will require healthcare practitioners to do a short survey online when they renew their licenses. And this is going to help us create a more accurate map for health professional shortage areas, help us tell who's using telehealth, what the scope of practice is, what services they actually offer, and where they're physically located, so we can get a more accurate map. Before that, the survey was entirely voluntary and didn't deal with telehealth. And lastly, Senate Enrolled Act 225 requires now continuing education 2 hours every 2 years for opioid prescribers. We're one of the last states in the country to do that. Congresswoman Brooks used that idea later as part of her ADAPT Act that she introduced in Congress. So we were happy to work on all three of those. Going forward, we've reconstituted all of our subcommittees to better align with the objectives that we have not yet met. We found the ones that worked on those bills that I just talked about weren't well situated for the objectives that we still had to do. So number one, we've got one working on integrated care, which is where a behavioral health professional will have an office with your physical health professional. And that would help reduce the stigma for a child, where if you've got a mental health issue, the child's just going to the doctor's office. Not anything new, not anything unusual, not anything to be embarrassed about. At our last task force meeting, we had presentations from IU Health, who's using that model in a program they call Choice, and also from DMHA, who's got some guidelines and recommendations for the program. Our main barriers, though, that we've discovered are billing. The dual billing requirements for physical health versus mental health are a problem. If the behavioral health professional meets with the physical health professional to talk about a patient, that team huddle is not billable to Medicaid. Dr. Hovershorn is a member of our task force, and she pointed out that all mental health treatment for children requires prior authorization from the insurance company, where physical health checkups and treatment do not. And that's a big barrier and something that we have to tackle going forward. We're also taking a look at mobile crisis response teams, and I have yet to find anybody who's against them. Also have yet to find anybody who can fully fund them. And that's really the issue going forward there. Telehealth has great potential here in rural areas. Officers could carry an iPad with them, and if someone is in crisis and going to jail isn't what's going to be best for them or required by the circumstances, they could use telehealth to talk to a clinician and get referred and directed to the proper resources. In other places, perhaps someone could be there in person. We're going to study whether or not we need to try to apply or create a grant going forward to generate data and show that these things work and work really well. I know there's one working here in the East District in Indianapolis, and it's a shame that we don't have more up and running already, because I think they're highly effective. We all know police officers have limited options. And in my situation, we've got a mental health clinic in town, and they can take someone there. Maybe that's what they need, maybe it's not, or they can take them to jail or not. And that's it. And having a clinician there or available by Skype or some similar technology can make a real difference to someone who's in crisis. Our subcommittee on school-based care is also examining the role of CMHCs and telehealth to see if we can provide more services to schools that want or need it. So that if a child is in crisis, they've got something that's already set up and already there, we don't have to refer them and hope that they set up an appointment and that mom or dad follow through, but we can get them going right away. We got to see unanimous approval from you. That's important. And we appreciate the DOE's work on our task force as well. Recruitment has always been an issue. We've dealt with several bills in the last sessions about the standards, like I mentioned with the earlier bill, trying to encourage mental health professionals to come into the state, to encourage them not to leave, and to remove government barriers. Our subcommittee there has met with the Commission on Higher Education. They're going to reach out to the Department of Child Services and also the IU School of Social Work to see what else we can do to get more people into those important fields. We've got a shortage there in Indiana, and that may be countrywide, but in Indiana certainly, and we've got to take some action there. We have two more subcommittees. One is on supporting development of models to identify youth at risk for substance abuse and mental health issues, and one to support efforts to ensure access to care and treatment for youth and parents with substance abuse issues. Both of those are taking a similar approach, where they're looking at models that are already out there. They're going to create a database and populate it with those models and gauge their effectiveness, and then go forward and see where the gaps are. And that's exactly where we are, and I'm happy to answer any questions that anyone has.
Do you have any questions?
You've got a lot on your plate.
Yeah.
Thank you.
Yeah.
Senator Head's been involved
Yeah.
with this commission, I think, from the beginning. I mean, you've
5 years, I think. Someone said the other day, and I was surprised.
look at the annual report, a lot of the kind of deliverables and action items, you've done great. So thank you and your whole committee.
Well, thank you very much. I've got a lot of fantastic people on the task force, and I feel dumb when I'm there because I know the least about the subject matter, but I'm amazed by what they do.
Thank you, Senator.
Thank you very
Yep.
much.
Next up, we have a educational outcomes presentation. Oh, no? What are we? Oh man, I
Mary
apologize.
Kay
I missed the last one there. Mary Kay and Sarah Sailors are going to present on your favorite topic, family recovery courts. So.
Good morning. Thank you for the opportunity to present to the Commission and provide you some information on the status of a partnership and collaboration that the Department of Child Services and the Indiana Supreme Court have surrounding the expansion of family recovery courts in Indiana. Many of you are probably familiar with the problem-solving court model, which is most represented in Indiana by the adult drug court model. We have approximately 96 problem-solving courts across the state, and some of those are our family recovery courts. We have 7 certified family recovery courts in Indiana, and in your materials you have a map of where those are located. We also have 2 more family recovery courts in the planning stages. Earlier this year, the Supreme Court and Chief Justice Rush and Justice Goff reached out to the Department of Child Services to establish a formal partnership for the expansion and further development of family recovery courts across the state. The emerging research nationally on family recovery courts supports this expansion because research shows that family recovery court outcomes have increased completion rates for treatment, increased or higher reunification rates among families, and decreased time in out-of-home placements. There is also a significant cost benefit associated with family recovery court participation. In part due to the opiate crisis and in part just due to a growing need for supportive services for families who are at highest risk for child maltreatment, we are partnering with DCS to have a significant expansion of our family recovery courts across the state. We currently have 7. Our objective for the next 1 to 2 years is to expand that significantly into at least every judicial district across the state, of which there are 26. Our hope is that we can even go beyond that as other states who have formally launched similar initiatives have gone from single-digit family recovery courts into 50 and more. So we're very optimistic about that. Where we stand in that process right now is on August the 1st, the Department of Child Services and the Supreme Court hosted a training on family recovery court best practices, which the target population for that training was our existing family recovery courts, so they could receive information on how to enhance their current practices. And then we also hosted an additional number of counties who are in the planning stages or who are considering establishing a family recovery court. So we're very excited about that, and our office in DCS will continue to work with those counties to either improve their outcomes or to implement programs and services in their communities. Some of the things that they learned in the training were how to identify the appropriate target population for family recovery court. It's similar to a drug court setting in the sense that that's not appropriate for every family, but there certainly are families that can benefit from these services. And helping them adopt a systematic process for identifying the appropriate families to receive these services. One of the challenges that recovery courts have is identification of the appropriate families to serve, as well as engaging those families successfully in treatment. So we're working with them, and we're hopeful that we're going to have continued expansion of those across the state. In your materials, there's additional information about the efforts. The Center for Children and Family Futures is a federal technical assistance provider for family recovery courts. They were part of our training. They're committed to working with the Supreme Court and the Department of Child Services for ongoing expansion, and we may rely on them in the future for additional training and technical assistance. And I'd like to turn. And we want to expand enrollment in those programs. In addition to the counties that are identified on your map, the prospective family recovery courts are located in Howard, Huntington, Knox, Madison, Monroe, and Vigo counties. So if we're able to implement programs in those areas, that will be a significant success. If you look at the map, we're sort of deficient in the northwestern part of the state, so that will be an area that we would like to maybe target in our future efforts. Our office and DCS has committed to having ongoing meetings to talk about how we can identify existing need, how we can support each other in our efforts, and how can we make these services available to families across the state. I'd also like to turn it over to Sarah Sailors for some comments.
Good morning. So in thinking about the model, I think about the unique perspective that our families come to us with the the challenges that they have, the needs that they have. I feel like if we are really committed to helping them achieve sustainable change, then we need to be progressive and alternative in our approaches with these families. As Mary Kay said, we have partnered with the Office of Court Services to inform our staff, to inform our communities about the role that the model can have within child welfare. We believe that the foundation that the model is built on, with collaboration, communication, support, and accountability, is the best way to service these unique families. We really feel like we need to walk with them in their journey to recovery, and that takes all of us to really get them to that place where they can sustain recovery. So we are hopeful that we are going to have many more courts jump on board with us, as I think that it's really a need that we've identified in the child welfare realm. Any questions for the department?
I know we're short on time, but for the benefit of really maybe me and maybe others that are not as familiar, what's the certification process? Is it nearly automatic, or is it?
No, it's a lot. It's extensive,
yeah,
Mary Kay.
Yeah, that's what I thought. Yeah. So if you could speak to that for a second.
The certification process is outlined under Title 33. There's a problem-solving court chapter that authorizes the Indiana Office of Court Services to administer support and training and certification for these problem-solving courts. A lot of the services that are provided in this setting, the court is already authorized to provide. What the certification process brings is a level of assurance for the court and the community that they are in adherence with evidence-based practices surrounding the services and treatment of these families. So they submit an application for certification which details their policies and procedures. There are rules that were adopted by the Judicial Conference that outlines the requirements, and then our office works with them to keep current on what the best practices are in this area. So we provide the training and technical assistance, and then the courts are recertified every 3 years.
Great. That's helpful. Thank you. Yeah, go ahead, Kevin.
Thank you for that. I'm a big proponent of problem-solving courts, and after meeting with Justice Goff and a phone call with Judge Kramer in Noble County about their court, this gets not just to intervention, but also prevention. So as we had that prevention conversation as well, this ties in really well. We talk a lot in addiction about a system of care or recovery-oriented system of care. This brings that coercive gentleness from the court to a system of care, and I think the outcomes, according to Justice Goff and Judge Kramer, can be phenomenal and life-changing for the kids and for the family. So this is a really important initiative, and I think it's well worth our support.
Any other questions? Thank you both. Yeah, great. All right, next up is we're going into the strategic priority of educational outcomes, in which there are 2 presentations. First, Melania Gant and Kathy Dunn. I messed it up, sorry.
Good morning. In essence of time, we're going to be very, very quick because we do have additional presentation today from one of our subcommittees, so we're very excited for that information to be shared. We have revitalized our Educational Passport subcommittee to have a new co-chair in addition to Dr. Ochoa, and that is Derek Grubbs, who has accepted that position, and he is out there. Yay. Thank you very much. So they will be progressing on that. And that is Dr. Ochoa is a very busy lady, and we just want to make sure that she's sharing the load. We did not realize she didn't have a co-chair for a little bit. And then the School Climate and Discipline Subcommittee has made some progress, and we're very excited. They had helped in creating and disseminating the surveys as required by the House Enrolled Act 1421, as well as House Enrolled Act 1356. And both of these surveys had to do with the school discipline practices and policies, as well as the bullying school policies that were in place. DOE is currently compiling that information and analyzing the data that will be coming from that. The survey is still open. They have about 48%. Oh, it did close.
It closed on August 10th. So
I'm sorry.
Let me just kind of
yes, my apologies.
Interject. We're on target for a draft completion by mid-September, so that our report can be submitted in a timely manner. So
correct.
Totally on track.
Yes, that's very exciting. I love when we're on track. So also, in addition to that, we have the report on foster and homeless graduation rates. That report is expected around January 2019. So we're very excited to have that population to be coming through so that we can begin to study the graduation rates of at least the two largest populations of our vulnerable youth, and we will hope to expect more data to come upon our NPH request. So with that, we will turn it over to Dr. Terry Miller, who will be presenting the deliverables from our Mental Health Supports in Schools Subcommittee.
Thank you both.
Okay, I'm Terry Miller, and I am very excited to be in front of you guys, you people. And I'm actually Assistant Director for Special Education at Hamilton Boone Madison Special Services, so I get to work in the field. So I love the fact that I get to work in the field and also get to work with people that are working on policy. And I also have been a System of Care Coordinator for 12 or 13 years. And so when I heard somebody mention System of Care, I keep thinking that through all the presentations that you guys have been hearing this morning, if we can make sure our System of Care coordinators are working alongside the rest of our groups, that is such a powerful opportunity that we have in our community. So that's my plug for System of Care. And then I'm also working on an initiative that does the Indiana School Mental Health Initiative. And so it's just, I'm actually a consultant with that. It's out of IU. And so I have some of my colleagues behind me that are helping to support me. And what I love about the work that we get to do, I hear the word collaboration a ton this morning. And just that as I was putting this and reminding myself of what we had put together, the collaborative work with all the different agencies is what's going to make a difference for our children. I know you guys all know that. So we'll go forward with what we have here. So I want to put, there's materials in your packet. And so just for you know what our group is supposed to be looking at, advocate for additional and improved services integrated into schools to address mental health and wellness. And I will say I've been doing the education thing for over 30 years. And I will say that right now, I think you all would agree that this is probably the most challenging, but one of the most exciting times in the world of education. Would you agree? You would agree. Good. So anyway, so because of this idea that we all need to come together, and if we're going to make an impact on our youth and on our families, most of the time they spend so much time in school. So how can we bring those things to the school to help our staff to be able to work alongside each other so that we can make a difference for our kids? So the two different priorities and deliverables we've been looking at, I'm not going to read those to you, but basically the whole idea of how do we put an infrastructure together so that would be successful so that we are making the best use of our resources in a collaborative manner. And that's the one we're going to talk about today. The other one we're going to be getting to, it's to study the training that's necessary to be able to integrate and have mental health professionals working alongside our educators in as effective and efficient as possible. So I won't go through all those, but these are the people that are on, not the people, the groups that are on our subcommittee. So we're well represented with different entities that are child-serving agencies. And then just this whole idea, and I think I'm speaking to the choir, I don't need to go into this, but social emotional learning and mental health is essential to be addressed in our schools. And so those bullets on there just basically talk about if we can do this preventative work and interventions and working together in our schools, then of course our communities are going to be much more healthy, much more healthy across the board, both physical and mental health. So the resources, and what I want to do is go through very briefly, because I know we're short on time, is the resources that we use to help to come with our recommendation, okay? It wasn't just one, it was looking at nationwide kinds of things, and I'll go through a couple of those in detail. So those are the ones we're going to go through in detail. So, and those are other additional resources on there. So you guys have all heard about the adverse childhood experiences, and I was thrilled to learn through the work that we were doing that we're starting to collect that through our health department, Dr. Box, right? So that was exciting to hear because it hasn't been done until now, and that can help us to look at what are our levels, and we know the prevalence of adverse childhood experiences in our communities is huge, okay? But it'd be helpful for us to know that, what's it look like in Indiana? And so we learned through our work that that's actually starting to be done in the state. So that's exciting. So these are just statistics that you'll find in your packet. You've already heard all these. It's wonderful very first presentation, so I won't go through these, but just the dire statistics that our youth are dealing with across the board. There's some more there as far as our suicide rates, how many kids are feeling sad, and so you'll see in your packet where our information that we got this from. I wanted to add this in here because the interconnected system framework is used across some different states across the country when we're trying to look at how do we connect and integrate the different services within the school. And this is what we use to look at implementation science and the theory of change when we're looking at putting something in place to make sure it's sustainable once we start doing it. So that's something that you can see on your packet, that if you're ever interested in looking at that, we have some live links to that. So, and then you guys we've already talked a little bit about systemic care, but we wanted to make sure that we're relying upon the different values and guiding principles that we know are effective across our communities that's been going on for 25, 30 years based on the systemic care values. And it really can make a difference to make sure we're integrating the youth and our families together as we're making decisions. And we want to make sure that you know that we're looking at the ESSA plan and the different pieces of that as far as in the mental health area. We won't go through those, as I'm sure I've read through that. And then we have 3 examples of people, I shouldn't say that, districts that have basically already done the recommendation that we're making, which is this idea of having a person dedicated to look at, a position dedicated to look at social emotional learning and mental health in our districts as a person who's been able to see it, what's sustainable and what's effective, okay? And just like we do reading and math, we make sure that we're all looking at that together as a district. How can we do that in a way that's effective for social emotional learning and mental health? Because if we have that going well, our academics working alongside that, we're going to have a big impact. So I won't spend a ton of time on this, but there were 3 different districts that have that position. And I know our small districts, I work in Hamilton County, where we had 3 small districts in northern Hamilton County, but they wouldn't be able to have one person doing it. They don't need that. But one person that could be part of their work to be able to look at what's the social emotional learning happening in the district in a district-wide fashion. So Evansville, Vandenberg is awesome, Hamilton Southeastern, and then Indianapolis Public Schools. And so I won't go through all this stuff. You'll have this in your package. You have
if you look
in
your packets, you'll see that the framework for that Evansville, they have an amazing diagram to show their framework. And this right here is just an awesome example of what Indiana is already implementing within their school corporations. We just need to spread the word and get that engagement from the other school corporations.
And what's cool about it, if you look at, thank you for pointing that, if you look at the bottom is what that phase 1, so it's basically developing a common philosophy. So we're all working from the same page, so we're using the same language, and so that's what this starts with. And many times, we want to start jumping into what interventions are we going to do, what screening tool are we going to use. Well, we need to do that in a way that's going to be sustainable by all having the same philosophy. It's going to be different for where I am as opposed to down in southern Indiana, right? So as we've already talked about, we need to be looking at our communities to make sure it's meaningful. But having that framework so that we know, and this is based on information science and theory of change, and putting all that together to make sure it's sustainable. And they've done it over, I think that's been 5 years they've been working on that. This is the Hamilton Southeastern, and just some data that they have as they've integrated mental health into their schools, and just seeing how many kids are getting served. 600 students were served last year through the mental health providers that are coming in, as well as working alongside their staff. Okay, so that's been a growing opportunity that they partner with one of the CMHCs. There's the IPS model, basically the same thing. If you look at the bottom there, okay, we're looking at that foundation of everybody having the same philosophy, working from the same page, and what are their priorities. Okay, so there's one, Indianapolis IPS, all right. So looking at this, what we found, and I won't read these because my vision isn't good enough, sorry how small that is. But those are the pieces of the infrastructure that we need, that we have found through all the work and the different sources that we used that are needed. And our bottom line would be, what needs to happen is we need that one person dedicated to that. So therefore, we propose that each school district, we would like support that each school district would have that person at the district level that is looking at social emotional learning and help to drive it in a systemic way that will be sustainable. And then from there, our next recommendations, of course, or suggestions or recommendations would be the next steps that happen to help the infrastructure be in place that we know works, just like Marlena pointed out from Evansville. So. Oh, yes, yes. Okay, and the other thing we'd like to think about is that, is there a way that we can look at these different models that we know are looking good, and then how can we look at those as pilots in other places where we think some things are starting to happen, and how can we help to put some resources towards evaluating that? And is there a way to maybe partner alongside, if we haven't approached them, the people that are looking at the impact that the Railroad Grant is having across the districts? Because we know that that's been an ongoing thing, and there's just been another set that's now being implemented, another group. So those two recommendations are what we would like to be considered. And the other one would be, if you guys are supporting this, are there ways that then we can make sure that our different professional organizations, you know, like school superintendent organizations, the principals association, that they are aware that this is something that you are supporting at your levels.
And the Lilly grant, just to be clear, the Lilly grant that she referenced is the comprehensive counseling grant that the Lilly Endowment has issued. They're in phase 2. And they're actually working on an evaluation right now to see how those who have already received the grant are producing effective results. So they are working on that evaluation right now. So that's something that we could possibly use their data to help support our data. So.
Questions? Yeah.
Good. Okay, I just wanted to share where the department was right now. This is a huge area across the state, obviously, for our K-12 world and pre-K and post-K-12. But regarding school safety, it comes up on a daily basis for us. You know, we hear from people, don't give us something. We need people. We need that mental health capacity. And so what we have done as a department to help with this, with the capacity piece, is reorg some positions. We have someone who is dedicated to the SEL, the social emotional learning, to help connect schools to those services and agencies that we're struggling to connect, and then to vet resources. There's a lot out there, and some of it, quite frankly, is not great, and then there's some stuff out there that's great. So we're trying to do a better job as a Department of Education to help with that. I know just this is an area, and I was just with the Marion County superintendents this morning, and they said, let's talk about mental health, let's talk about mental health, and let's talk about mental health. So we talked about mental health. But that is just an area that continues to come up, and we have some great partners, but we knew as a Department of Education we had to regroup on some things. Also in our ESSA plan, we have, for the federal plan, really stayed true to those subgroups to watch academics, behaviors, grad rates. So we're hoping to bring that state plan along, but from the federal plan for Indiana, we did as a department say we're watching all those subgroups carefully so we can let that data drive some of those decisions and more of our capacity. So we're working on that. We're nowhere near perfect, but it is a big concern out in the field.
But what I'm really excited about on that is Christy Berger, yeah, she's here. She's here. And then Bethany from VMA, where are you? You're still there. So I know that you guys, both those departments have looked at this and they were on our subcommittees. So that makes, yeah, so we have to.
So Christy Berger, just stand up again. She's our new Assistant Director of Social Emotional Learning. So we will all be working together and connecting all those pieces in alignment with Dr. Miller's recommendation to this group.
Committee? Okay. And I don't know what all these acronyms are, especially the SOC, System of Care, but it seems to me that two groups that should be included if they're not already, and if they are, just tell me, would be a representative DCS and juvenile probation. Are they, is there a reason they're excluded or not included?
I think.
They deal with these youth all the time and
Oh, that's right, you are there.
so DCS, what about a juvenile probation representative? Yeah, well, Department of Corrections, not juvenile probation.
And that, yeah, I think the thing is either serving on the task force or how do we make sure that we know, because there's also the, the mental health and addictions in schools and stuff that's kind of a different subcommittee. So how do we make sure? Yeah.
Prosecutor, when you have behavioral issues, sometimes the first person that gets called is the juvenile probation officer or the prosecutor to come get this kid or do something. And
we know our juvenile detention centers.
We don't know what services are available, and this would be at least educational from that perspective.
Yes. Absolutely, yes, because we know our detention centers are and our mental health providers.
Yes. But we actually should have more information about that from the needs assessment that was part of the Senate Enrolled Act.
Yeah. 30, yeah. Yep.
That needs assessment is in the process of being completed. It should go out fairly soon to schools.
Okay.
Once we have all that data from the school discipline survey as well as that needs assessment, I think we'll be better able to respond to that question.
So it's fair to say we'd have more definition on the second part of the recommendation once we have the needs assessment complete on the...
Yeah, and I want to be clear on that first part where we're a person to designate. That is, we have at the district level a lot of designees for McKinney-Vento, for school safety, and so a lot of times that is just that designation of who are we going to, who do we need to filter that information, not necessarily go hire 5 more people. Exactly. So I just want to make that clear. Yeah.
Thank you.
Yeah.
But even that needs assessment is a big lift. Just understanding who could do that or who might already be doing it, we don't know. Yeah, okay.
And I wonder from that needs assessment, just to put this plug in, since I work in the districts and get to see how stretched our people are, and if it comes up that this needs assessment shows that we might not have the personnel to do that, there may need to be, do we need some more resources to do this?
Meaning a designee that's sharing the responsibility of both physical school safety and mental health might be,
Which would be like
a tough lift.
Collaborative thing, yeah, definitely.
I just wanted to know where that stood, so.
We also offer strong guidance of what type of background and knowledge base that person would need in that role would help schools to appoint the right person.
Right.
So I think coming from all perspectives, we can definitely help create that.
More questions? Anything else?
Call for a motion to approve the recommendation that each school district designate personnel to facilitate and oversee the integration of social emotional learning and mental health in schools and advocate for funding in the future for whatever those needs might be. So all in favor? Oh, second. All in favor?
Aye.
All opposed? The recommendation is approved. Thank you. Thank you, Dr. Miller. Yep.
Let us know what else you need.
As we move, before we move on to the next piece, I might ask Julie, is there a way, and we were talking about this, is there a way that we could move the roles and responsibilities to an executive committee vote? I mean, just, it's, and then as far as your roundtable meeting report, we could electronically do that? Okay. Okay. Well, no, I just want to make sure we got 10 minutes left, and I want to, we packed a lot in. Great. Okay. Thank you. Okay. Well, next up, we've got committee updates. Tamara Weaver and Tyler Brown on the data sharing and mapping committee.
Morning. Thank you very much for the last meeting's approval to sign the MOU with all the partners for our info sharing guide. I think we are in the final stretches of receiving the last of the signatures, but we've already put the implementation into effect. We have identified legal contacts from each of the agencies. Those have been assigned, and we've reached out. We'll have meetings with those attorneys this week and next week to go over the framework for updating the info sharing guide. Tyler and some of the members of our committee have developed a great, easy, technologically savvy way to do so, as opposed to our old copying and pasting into spreadsheets to this, to that. So there'll be an online form, essentially like a survey, that agencies will be able to see prior entries, make any changes, and give their approval of the entry, and then we'll be able to, as a committee, compile all those results and push out any changes into the app version as well as the web version. We're making just a few changes this year around adding record requester for foster parents and doing some separation in the mental health, and substance use disorder area to make those record requests a little bit clearer. In terms of app updates or user interactions, we keep track of those monthly. So in the past month, we've seen 168 new users of the app, 144 returning users, and over 2,500 app interactions. We don't track the web version of that, but that's just the app itself. And we track those monthly. We have a couple other statistics, so if you're interested in those, you can always let us know. We anticipate getting the updates from all of the contacts and the agencies by mid-September to be on track for a January rollout of updates, and we'll try to keep that schedule going forward. We've adjusted it slightly this year just because of the timing of the MOU, but otherwise I think we're well on track to get this process started this year and then continue it going forward in the future.
Good morning. So I just have a quick update on our work with the Educational Outcomes Task Force with their data request regarding graduation rates of vulnerable youth. So at the last committee meeting, I did update that we, NPH had DSAs with all of the relevant parties. So since the last meeting, I've had several meetings with folks at FSSA, DCS, and Department of Education, talking through the request. I have a couple meetings for early next week where we're actually getting the parties together. So hopefully we're moving in the right direction to actually get the data to where we can present something to the commission.
With regard to aging out of foster care, or services to 23, those numbers will be really beneficial to know what the past graduation rates have been for kids in foster care as we support the initiative on extending. So we look forward to getting it this fall. Okay. Does that work? Right.
Is that a question? Yeah. That was a question. No. Will it be ready in the fall? Any other questions? Thank you both. Next up's Catherine Dolan, communications update. Big update.
Good morning. I'm Catherine Dolan, the Public Information Officer for the Supreme Court, as well as your communication chair, and I'd like all of our communication members who are here this morning to please stand, and hopefully in just a moment be helping to pass these out. We formally provide to you your annual report. I know Julie is very, very appreciative of all the hard work that you put into providing her with key information, and I'm certainly very appreciative of our communication team members who have helped Julie to provide this. We have a communication plan ready to go for this afternoon. If you would formally approve this annual report, where we will put out a press release as well as tweet that the availability of the report is online, and put out what we call billboards on the state website linking to the electronic version of the report, and we have 100 of them printed and ready to give out. So I believe that a motion is needed for formal approval of this report if you are so inclined.
We have a second? Second. All in favor?
Aye.
All opposed? Annual report is approved.
Wonderful. Then the communication members will help pass this out, and we'll get copies to everyone, and if you'd like any copies, let us know.
Thank you, Catherine.
Thank you.
Amazingly, we caught up somehow, so, against all odds.
All right, then forget that tabling. I'm going to take my 5 minutes. I didn't actually put myself on the agenda. Oh, yes, I did. Okay, so there's actually one action item under mine, which is an update of the roles and responsibilities document. This is in your packet. You approved it, I don't know, 3 or 4 meetings ago, and it dawned on me that we didn't put in a section for the chair, which is kind of an important role. So I've added that, and the executive committee has looked it over, including the chair, to describe kind of the duties of the chair. Some of those are in statute, and some of them are in other processes that we formalize, such as the communication processes. The chair has to approve any press release that's issued by the commission, and some of them are just kind of what happens, like the chair facilitates the meeting. So this is highlighted. It's section 3 now in the roles and responsibilities document. I offer that for your consideration and potential approval.
We have a All in favor of that very complete motion?
Aye.
All opposed? Amended?
Okay, and then just the last thing, I just wanted to mention that I had the privilege of traveling to Annapolis, Maryland a couple weeks ago, August 2nd and 3rd. Flight got canceled and I ended up another day there because of thunderstorms. But anyway, it was a meeting of executive directors of state children's cabinets. So I got to meet and network with folks who do my job in other states, which was really, really helpful. I'm grateful to the court for supporting my travel out there. I just included the agenda from that meeting. It was a great just a great opportunity. Still a lot of food for thought. I don't have anything really concrete, but just information about what other states and commissions are doing with regard to youth engagement, race equity, state and local collaboration, which is something interesting that we haven't talked about at all. That might be a future topic. So it was a great opportunity. I just want to thank you for your support for being able to do that. That is my update.
Great, and I guess we've got an item for discussion, and maybe we'll leave this, the future meeting topics. I think it would be helpful for the commission members, just as you go about your daily lives, you want to send Julie for consideration our executive staff meetings, as we could expand the possible list of topics. And I think we've discussed some of them in recent meetings that we could add to the future meetings moving forward. So that would be very helpful. And then I guess our next meeting is it's October 17th. 2018, so in the state library, beautiful state library. So I motion to adjourn. Do we have a second? All right, all in favor? All right, motion is adjourned. Meeting is adjourned.